Hi, everyone. Welcome to conducting the SASH Assessment and Documentation. Stefani Hartsfield, for anyone who doesn't know that yet. And I'm here with Sarah Mariani. And we are going to go over the assessment as well as some tips around documentation and also a little bit of time on just kind of working with a computer when you're with a person in their room, because that can sometimes be a little bit of a disorienting for some folks.
Okay, we're going to start out with a game to get everybody's mind thinking. And my Vanna White, Stephanie over here, to start out, why SASH? Why should people join SASH? What are the 3 areas that we focus on to help ensure that goals are met?
You guys can shout out answers. Feel free to.
Education.
Yes. Education. You got it. Who said that?
Colleen.
Colleen. Education and self-management. Coaching, particularly related to chronic health conditions such as diabetes and arthritis. Colleen, you can go to that little bag and get a piece of champagne chocolate.
Transitions.
Transitions, Janet.
I want a chocolate.
Transition and support after a hospital, nursing home, or short-term rehab stay.
So go get a chocolate wherever our bag is. Somewhere
Yep,
here.
bag is right in the back left-hand corner, Janet. And the last one.
Provide resources.
I'm sorry?
Provide resources.
Resources. Resources could go under education and self-management. There's one other.
We're looking for one other,
do.
yeah.
It begins with a P.
Other sites can shout out too.
Yes.
Personal goals.
Person-centered planning.
Yes. No, did you say person-centered planning?
I did.
No, I'm sorry. I got excited about it, but it wasn't it.
Do other sites, do you know the question we're looking for? Go ahead and restate their question.
What 3 areas are focused on to ensure goals are met in our SASH program?
We've done education, transition, and
Participation.
Oh, it's a P.
what was that from the other site?
Participation.
Getting there.
Program.
What do we try to do to ensure that they don't get sick or their conditions don't get worse?
Prevention.
Prevention.
Who was it that said that? Was that Michelle?
It was.
It's Michelle. Great, Michelle. Good job.
Preventative healthcare services and coordination. You go to that little Champlain chocolate bag and grab yourself one.
And everything else that y'all said is good too. She's got it. Okay.
Okay, so to work on prevention, transition, support, education, self-management, how do we find out the information so that we can help these participants? We have to do a what?
Person-centered interview.
Both an essential part. The assessment and the person-centered interview to try to figure out what this person is all about. Has anybody done an assessment before?
Yes.
Yes?
Yes.
Raise your, yes?
Part of one.
We are doing them.
Okay. Has anybody seen one but not done one yet?
Yes.
And has anybody never seen one and has no idea what I'm talking about as far as what the assessment is?
I've never seen it.
So is it correct that everybody's somewhat familiar with the assessment that we're going to be talking about?
No, we have some. No, Montpelier has some people who haven't seen it.
Okay,
We've got some
Montpelier
people
hasn't
joined
seen
in
it.
Montpelier.
No.
Okay, great. So to start out, when the SASH coordinator, it's generally the SASH coordinator that goes to meet with the person to sign them up for SASH and do the person-centered interview. We will give them an information checklist for the SASH assessment. And Stephanie has it up on the screen. This is in your packet. It's just kind of a guide or tools to let the person know what they should help get ready before we go do the assessment. So if we're doing the assessment, they have the medications ready, advanced directives, all this information, they'll have it right there. So if we ask them, they're not going to search for something and they have no idea where it is. So it's really a time saver and helps us get organized to start that. So that's the checklist. All of these forms that we'll be talking about are on the forum as well. So feel free to write on this if you'd like. You can print out more copies, and it's right here on the forum. Another tool that you have in your packet and on the forum is a guide to conducting the SASH assessment. This will just give you some key points as to what part you're doing as a reminder. Another thing we have in there, the medication administration and assistance procedure. This is as far as what we can do for helping them with medications. These are tools to read over, and once you get familiar with these, you may not need them all the time, but doing the assessment the first 5 or 10 times, it may be really handy to have. And we start the assessment first with the SASH coordinator's part, and Stephanie's going to start going over that, and then we will transition to the part that the nurse does.
Okay. So, okay, great, thank you. And that guide to conducting your assessment may not be in all the packets, so we'll make sure, I mean, it's on the forum, and I'll make sure you guys all have it. So thanks for bearing with us. And basically that guide to conducting assessments is kind of a step-by-step key points that you want to hit, and Sarah's going to talk through those today, and you guys can take notes, but just know that that's available as kind of a cheat sheet when you're getting used to going through it, making sure of points that you hit on as well. And we have the instructions in here as well if you need that. So I just want to reiterate that info checklist, this stresses the importance of coming up with a workflow between each SASH coordinator and wellness nurse for what works best for the 2 of you or 3 of you at your site, depending on your site, is you all really want to communicate well. The SASH coordinator is usually going to be the person who leaves this with the participant, either after they just sign the initial paperwork and they say, let's schedule an appointment with your nurse, or the nurse will be coming, and when the nurse comes, these are some things you'll want to have with you. That way, if their family member sees them in between the appointment, they can come and help them find some of these things they may not know. It'll make it much more time efficient when the nurse gets there. And really, you want the nurse to be able to spend the most of their time talking about clinical things and really spending time on that, and not spending time digging around for their advanced directive paperwork or digging around for all the medications, things like that, or old discharge paperwork. So this just helps them get prepped. You can also give this to them at the person-centered interview at the end and talk through it. Another helpful tool that I wanted to show you, this is, again, is on the form, it's not in your packets, is this little cute appointment reminder that we have, and it's on the forum. You can make your own. One of the sites came up with this a couple years ago, and they leave this with the participant that says you have an appointment to meet with your nurse on Tuesday, June 24th at 2:30, and they might hang this on the refrigerator to remind them, family members see it, and again, leaving those 2 pieces of paper with them so that they know when it's coming. It's a visual reminder. Those are some really good workflow tools. For the most part, what happens is nurses have a pretty regular schedule, and it's usually helpful if the nurses say, especially if you're starting up a new panel, nurses might say, okay, I'm going to be here Tuesday and Thursday from 8 to 12. Can you book me assessments at, 8, 10, and 12, or something like that, and whatever makes sense. Those are the appointment times. Will you have them pre-scheduled so I know the apartment and the time to go to, so when I get here, I can just hit the ground running. And then they also kind of have a weekly check-in time, too, with each other. That's usually what works best, so the nurses can just go, and they might want to have some time in the morning to check in with their SASH coordinator or review some files. But that's really what works best for most people. Some nurses do like to schedule their own assessments. They like to call the participant, get them scheduled. That's fine too. Do what works best for you, but just make sure that the 2 of you or 3 of you are talking, and you figure out a workflow, keeping in mind what works best for your site and for the participants. So that's kind of my tips, and then you can modify it. Tips and tools. So the document that I have pulled up right now are what are called the SASH Coordinator Detailed Instructions. This also right now works as what we call the paper assessment. And so you're going to use this if you don't yet feel comfortable entering information straight into a computer or an iPad when you're with someone. Or if you're just still getting used to it, or if you don't have an internet connection in your building so you can't enter directly, that means you have to enter later. So just so that you know that. That's what Sarah and I are going to be working from. We are working towards getting something that's called that really is just a paper assessment that doesn't have instructions on it, and it's all one thing and one piece of paper. So we're working to get you guys that hopefully in the next couple of weeks. But this one does have the instructions on it. Still use it for that. And this one has SASH coordinator and nurse broken out into 2 different documents. I'm not going to go over every question. These instructions are written out really, really nicely and clear. One thing, so the first thing you do if you're a SASH coordinator is you're going to be creating the file in DocSite, and that requires the demographic page. But you can follow this on paper. When you're sitting in an apartment with someone, just follow the prompts on here. The yellow fields are pretty straightforward. Last name, first name, date of birth. Now, if you're following this on paper, you might see race, and that doesn't feel good to ask, or they don't want to answer it. That's fine. There's a not answered option. You can skip that stuff. Get their address, email, things like that. Most important, get their Medicare or Medicaid number, or both, whichever they have. Okay. And then from here, the questions in here are pretty straightforward. What's their emergency contact information? Have they signed the use and disclosure form? You must answer either yes or no, and that just means are they full benefit, and there'll be a date with that. You can skip reason no longer participating in SASH because you only fill that out when they stop participating, they move, whatever. The rest, contact preference, that's pretty easy. Living in the community at large, I just want to pause on that one. What that means is, if you have a hub building, the answer to that is no. They live right in the building that's your SASH hub. If they live anywhere else, they're a community participant. You need to say yes. That's how we track if they're community or they're not community. So they may actually live in a small building, but it's not really a hub site. That still makes them a community participant. So this is the question that marks whether they're community or not. Okay. Primary support, secondary support, that's, who are the support people in their life. Contact, you just enter it there. Primary care provider, yes or no, and site and contact information. Right now, all I can say on that is try and enter these as consistently as possible. We're pulling together some cheat sheets to help everyone out because they're free text. The state can't agree on populating a list. It would be great if it was a drop down, but we're going to try and we're working with the Blueprint for Health to make some pre-populated cheat sheets for you, but just try and be consistent. I don't know, that's the best I can say. Specialty providers, yes or no? There's only room right here for one. There's some workaround ways to get more than one. Or what we found out one nurse does, which is a great workaround, is she just puts a comma and lists them all right on this line, which is also fine. So you could just list 4 of them and just separate them by comma. So that's a fine cheat workaround. Pharmacy, do they have services from these other agencies? Pretty self-explanatory. This insurance question's a little bit redundant to the beginning, but the purpose of this right now is just to know, do they have dental or vision? Because that'll help to know later when they say, I need new dentures or I need glasses. You just want to know if they have it or not. And then legal guardian, advance directive, these kinds of things. You just want to ask those questions. That's pretty much it for survey 1. And then there's detailed instructions down here about how to record what you did, but I'm going to kind of skip over that because that's very DocSite related. Just know at the end, you just want to track that you spent time with them in their home asking these questions. And I think if there are questions about what to mark or how, you can ask me. That's more about tracking it in DocSite. So that's all the SASH coordinator does is survey 1, basic demographics, and then before the nurse goes in, what's a great workflow is to print out a summary of that from the visit planner so that they can review it, what they know so far about the participant before they meet with them. So any questions on that survey 1 basic information from anyone?
So if they weren't living in the community at large, what would that look like?
They would be living, if they live at Decker Towers,
Yeah.
They don't live in the community at large. That you say no, because they live in a building.
Oh, okay.
That's what that means. Yeah. Good. Any other questions?
Care site. I will be dealing with a lot of people who live in New Hampshire, so so they definitely won't have a blueprint team. Do we have any preferences around those situations where they might see providers out of state?
Yeah. Sarah, what was the first part? I know they'll live in New Hampshire. You said they won't have what? A community health
They
team?
won't
Is that
be
what you
part
said?
of a blueprint primary care team. So do
I
we
think-
have any preferences?
We don't. I know what we want to do is get working closely with Dartmouth, and we already have a good relationship with that. So I would just document who their primary care physician is and primary care site, and then we'll figure it out from there. And we're going to be working on how to coordinate with Dartmouth around that. Yeah. Cool. Yeah. No, good question. Any other questions? Okay. Great. Okay, we're going to move on to the nurse part now.
Okay, please stop. Feel free to stop, to interrupt, or let me know if you have any questions or comments as we go along. The part that Stephanie just ended with, where there's specialty providers, oftentimes I will go through and review that part again as we go through, health history and medications and everything, because it might bring up cues or keys and be like, oh yeah, I do have a heart doctor, or I do have a neurologist or something. So I'll oftentimes review that as we get into more detail with the participant. Okay, the wellness nurse, here are the instructions, and our part starts out with the medications. And I asked to physically see the medications. I don't just want the list. I'd like to take a look at the bottle. I, generally see when it was prescribed, the whole deal. And I'll try to take a look in to see, if they're prescribed 2 days ago and they're all gone. You just can get a lot of information by taking a look at the actual bottles. And we write the name, the dosage, when to take it, why they take it. And why they take it sometimes brings up health conditions. So I keep that in the back of my mind as, every medication they take, I say, why do you take that? And sometimes people know exactly why they take things, and other times they have no idea. The doctor tells me to, I'm taking all these pills, and I have no idea why I'm taking it. Then we go to the allergies.
Yep. Can I make one quick note? I just want to say that, especially for the nurses to know on here, is that it's really good. This is the one thing that I probably wouldn't enter live while you're with the participant if you're comfortable using the iPad. This amount of information that on this sheet that you see on the screen is really good, and we really want to have all of it. DocSite doesn't ask these same questions, but you want to have this information. So with medications, I would actually record it all, and you could even just bring this piece of paper and then transfer it later. And you can still record all this in DocSite in that there's a free text, like other information in the medication field, because why they're taking it, like Sarah said, is really important, because sometimes they're taking a hypertension med for another reason or whatever. But so this is a really good chart to bring with you and then transfer the information. Okay. I'll be quiet.
Okay. And same as with the allergies. If they have a bunch of allergies, under this part, I also do sensitivities or anything they just don't want to take because it made them feel however. So allergies, sensitivities, and anything they just don't want to be prescribed or given under the allergy section.
Sarah, why don't you go over just based on this, how you normally kind of ask about chronic conditions? And
Between the medications and then the medical conditions part, I take a lot of mental notes so I don't have to specifically ask people all of these things. And, starting with the medications, you get a real good idea as to why these people, what their chronic health conditions are, without even asking them. And sometimes things are uncomfortable for them to answer if they've got a history of depression or PTSD. So I don't always come out and say, do you have this? But, go through and is it correct that you might take this for, is it correct that you might take it for a certain reason, or they take it for a reason that's not even related? They're trying to quit smoking. That's why they're doing the Wellbutrin. It's not because they have anxiety or depression, but they've been prescribed it for that. And under the medical conditions, under Survey 2, I say I'm going to run through a list of health problems or conditions and let me know if you've ever had trouble or incidences with any of them. In addition to these medical conditions, I ask if they've ever had any type of cancers or any major surgeries. And I do that in the free text. Oftentimes, different diseases or cancers will come up in conversation. And sometimes you go through the whole thing and you have no idea that they've had, breast cancer and a left mastectomy, and so I've gotten a habit of asking those things, just so if you're working with them down the road and they have a complaint or a problem they'd like to check out, you know what's going on with them and know the history they've been through. And next we do, a lot of this is self-explanatory, so I'm going to skip over parts, but please let me know if you have questions or ideas. This is interesting. Does the participant have a personal emergency response system, such as a lifeline or link to life? And I was doing this with a participant last week, and she says, "Oh, yes, dear, I've got one." And I said, "Oh." I said, "Great." I said, "Which one do you have?" And she said, "I have the lifeline." I said, "You know, do you wear the pendant around your neck or the bracelet?" "Oh, I don't wear it." So we ask if they have one, but we don't ask if they wear it. So I've gotten the habit now since last week of, you know, do you wear it? And you should wear it if you're paying for it and do have it. And since then, since I did the assessment with her about a week and a half ago, she fell and broke a rib and had to crawl over to the nightstand where she kept it to get up there and push the button. And now she wears it. A little side note on that. The patient's self-reported health and wellness goals. And this is something that oftentimes when I'm doing the initial assessment, they may not know the answers right away, but once they get into the SASH program, we get to know each other a little bit better. These are ideas or goals that they come up with, and so I go back and do something. Sometimes they don't have any, and I'd like to exercise more, get my blood pressure down, get off the blood pressure medication, do some yoga, relaxation. It can be anything. Get out walking, get some fresh air.
I'm just going to say, this is one where you'll want to compare notes with the SASH coordinators, because they will have done the person-centered interview, and they'll look at what you find in the assessment to then create the healthy living plan. So they may have nothing here, and they may have something, and you guys want to compare notes to go back, so that when the SASH coordinator goes back with the participant to do the first draft of the healthy living plan, something may have come up here, because people sometimes share something different with a nurse than they might have shared with the SASH coordinator, and then the SASH coordinator can follow up to build that relationship, because they have more time to say, you know, Sarah shared with me that when you were together, you mentioned that you're interested in walking a little bit more. Can we talk about how you might want to make that happen? So it's really good to share some of this with the SASH coordinator, and then they can bring it back and see that you're all a team working together.
Thank you. And sometimes there's obstacles. Why haven't they been able to do this? I'm planned to have my hip surgery, and after my hip surgery, then I'll get back to walking on a daily basis. Sometimes it's, you know, I'd really love to go to the gym, but financially I can't right now, or I don't have a ride. And so those are things that we can kind of group together with our SASH team to help them achieve those. Vital signs. It's great to get an initial set of vital signs with the participant, so that we know if we ever go back to them, we have something to compare it to. Generally speaking, I do this at the end of the assessment, just so we've sat for maybe an hour or so, and the participant's a little bit more relaxed, and you know, they're more likely to have their baseline vital signs and blood pressure, versus you walk in, you're in their personal space, you're going to be asking them all this type of personal questions. Did you have anything to say about that, Stephanie?
Oh, I was just going to say, so at the assessment and the reassessment, so at least once per year, you do height, weight, and blood pressure on every person. And then on the other vital signs, just use your clinical knowledge based on what you've learned in that hour. And you may not do any other vitals, but if they have something,
so I do. Not everybody's got a scale. And I don't have a scale at my sites, although we're working on it, the wellness nurses, to have one for, because a lot of times doctors want daily weights done for somebody who's got congestive heart failure and, fluid. So I ask them their last height and weight. I always do their blood pressure, temperature, not always, but pulse and oxygen level I do as well.
And I definitely think if someone's mentioned chronic pain or pain
Yes.
somewhere, you're going to ask them their pain scale. And I would do that regularly when you check in with them, because you want to see how that's fluctuating over time. Yeah.
And I just want to mention, going through this whole assessment, the SASH program is voluntary for them, so I don't want them to feel uncomfortable. And I say, I'm going to ask you a bunch of health questions, and some of them are personal, and if there's something that really bothers you or upsets you, you don't have to answer it, and you don't have to participate in any part of this that you don't want to. And then it just kind of puts them at ease. The stress is a little bit less on the person. We'll get to the cognitive piece, and I'll talk more about that. Okay, we're down to alcohol and tobacco use. This is pretty self-explanatory. If they answer yes in the alcohol screening, we go to the CAGE assessment. And when you have to do a second part of assessment, we do that with the emotional health as well. I try to just transition seamlessly, because if they answer yes, you just go to either scroll down or go to the other page and just keep going on the questions, not, oh gosh, yeah, it looks like you're failing this survey. Let me do some more in-depth questions with you. So I try to just transition so they have no idea that in the emotional health or alcohol screening that there was
an option to do less.
Prompted me to go further. A bell doesn't go off or anything. And tobacco cessation is a huge thing in Vermont, and I know we've gotten grants, and we're going to be working on different quitting smoking projects if they'd like. And sometimes when I'm the wellness nurse there, they see me and, oh gosh, I can't smoke in front of the nurse, and they think I'm going to hound them to quit smoking. And I always offer, if you're ever interested in quitting smoking, I'll be more than happy to help you find a way to quit or refer you to programs. I'm not going to hound you. I'm not going to tell you should quit smoking. I'm not going to tell you it could give you cancer. I really don't hound them, and I find you have a much better relationship when you put that aside. And sometimes I'll go out in the smoking section to discuss things with these with the people who are constantly smoking out there that are in part of the SASH program. I don't light up with them, but I will sit and have the conversation. That's kind of in their comfort zone, and you build a lot of trust and good relationships.
I was going to say the phrasing is weird on this question, and she's tried to explain it in the sidebar here. It's just this question, tobacco use cessation intervention. If I was asking this question, I would say, if they had answered, yes, I am a tobacco user, are you interested in quitting? Would you like help with that? That's what that means. And that's how I say it to someone if I'm asking it. I would not say, are you interested in tobacco use cessation intervention? So I think you guys could figure that out. But are you interested in quitting? Would you like help? And so they can answer yes. You can check multiple things on this, so it's a little confusing. But they could just say, yes, I don't know how, or yes, but I don't want to talk to anyone. I just want to do it on my own, or yes, but I pharmacologic, I only want to do the patch. So that's what this question means. And if anyone gets confused, you can just refer out. You can ask us. Don't, again, like Sarah said, the key is to put them at ease. And yes, that there are a lot of strategies with motivational interviewing or other things around menus of options. If someone has hypertension, there are a number of things they could do to lower that. Quitting smoking is one, but so's eating less salt or whatever. They don't have to quit. If they're 85, they've smoked for 60 years, what? Maybe they should just be happy, right? So.
Anybody have any questions thus far? Exercise. Exercising can be anything from walking in their hallway daily to riding on their bike in the exercise room, swimming. I ask them if they exercise, anything out of their normal daily activity. One woman has been dancing to lose weight, and she's lost 30, 40 pounds by walking the hallways and dancing in her apartment. And that's a great thing. And most of our sites have started a walking program that encourages kind of everybody, and we're doing you can walk or wheel. So it's not just a walking program, but it's including anybody who wants to get some fresh air and social time to come with us. Does anybody need assistance in obtaining the following? Eyeglasses, hearing aids, dentures. This is really becoming, at one of my sites, something that has really taken off and running. A lot of people are needing new eyeglasses and dentures. And dentures are really hard to come by in Vermont nowadays. There's like one spot in Chittenden County. I'm not sure throughout the state, but dentures are a huge hot commodity right now, getting new dentures, and they're hard to find, and they're expensive. So at SASH team meetings, this has been one of our topics that we're discussing, is coming together with CVAA or your agency on aging and what tools and resources they have to help get this person eyeglasses and dentures. Let's see. Health rating. Ask them overall how they would rate their health. And on paper, they might look really, really sick and have a lot of health conditions and medical problems, and they're still working, walking, talking, driving independently, and they may say they're excellent, where on paper it looks like, they should be in a nursing home. And on the other aspect is there's medically not much the matter with them, and they can hardly get out of their own way to do anything. So it's their version. It's not how we would rate their health, but how they would. And last week I had somebody not want to answer that question. And I just continued on. So flu, the pneumovax and shingles vaccine. It's just good to get a baseline of, does this person generally get immunized for the flu? And we have on the forum, there's a presentation on the flu and you that SASH coordinators and nurses can present every year that kind of educates people. And if you know it's somebody who's gotten the flu shot every single year, it doesn't have to be the exact date, but say, fall of 2013, the pneumovax and the shingles vaccine is something that's up and coming and become more popular and recommended by our seniors. Emotional health is the other one I was talking about when we ask this if they've, this is the one where we would transition to another survey if they did have.
No, that's PHQ2. We're not there yet. It's a little bit.
Okay.
Yeah.
Okay. Emotional health.
Yeah. These emotional health questions are actually, they were supposed to target isolation a little bit. So they're extra, and we need to transition to a true isolation scale. I mean, still ask them, but it's the PHQ2 is the one that'll lead into the PHQ9. You'll see that a little bit later on.
Can we skip to that?
Yeah,
now?
You want to? Yeah.
So the emotional health, and
this is Pete right here.
Yep. I transition these. I kind of do them simultaneously because they kind of go well with each other instead of doing one and then doing the emergency room and then going back to depression. This asks if they have contact with their friends and family and then bothered by anxious or nerves. And then you could go to, in the past couple weeks, have you had little interest or pleasure in doing things? And that's kind of a transition. I do the two of them together. And then if this one scores, as Stephanie was mentioning, then you go on to do the second part of it. A thing to consider in this area of the assessment and in general is, what time of year are you doing this? Is it winter? Is it a gloomy day and it's been snow and they've haven't gotten out of their house in a month? Do they have seasonal affective disorder? Are they at risk or having isolation? Is it around the holidays where people have a really tough time? Is it an anniversary of a loss of a loved one? So depending on what time of year you do this survey, it definitely could change. And I always do a mental note and a document if it is in the summer or if it is the time of year. And I say person says that they usually have a tough time around the holidays. Medical status about ER visits and hospital stays is self-explanatory. If you're doing the initial assessment, one of the questions says, if you stayed overnight hospital to home, was a SASH protocol followed? In the initial assessment, that wouldn't apply to us, but reassessments.
Don't worry too much about that. Don't worry too much about the SASH protocol on that question. So really, we just want to know how, and someone asked us, if someone's a brand new participant, have they been in the emergency room recently? Is this a referral coming from the hospital because they've been there? So you kind of want to know that information. And then we definitely do want to know, as they're a participant, are they going into the ER? Are they transitioning out? How frequently are they going? So it's more for that. Don't spend too much time worrying about these SASH protocol followed questions. That's not that important. Just laying it out there.
The ADL and IADL is self-explanatory.
Oh, wait, you're going faster than me. Hold
Oh.
on. Did you do medication review? Right here, this question.
Okay, medication review. Sorry, back on track. Does a participant need assistance in managing their medications? And oftentimes, they're a little hesitant to answer this question. Would it make it easier if we got you a box Monday through Friday and you could pre-pour your pills, or do bubble packs? What do you use for the systems? How do you remember to take your medications? Do you just take them out of the bottle? Sometimes they take them and then they flip them upside down. I like to take a look at if they do have an alarm box or the Monday through Friday, whatever system. I like to take a look at it and review how they take it. And where do they keep their medications?
And I think asking them to show you how they use that system is really good, especially if you're getting hints that the person could have some cognitive impairment. But even if they don't, it's kind of like that lifeline. If you just say, do you have a lifeline? They say, yes, that's great. And you don't say, well, are you wearing it? It's the same thing with, well, show me your system for your medications. Because someone else may have set up that system for them, and then they really don't know how to use it. And that could be why they're falling every other day, is just because they can't use their medication system and then their medications are off. So, and the physician has no idea, because as far as the physician knows, they've prescribed it, they're going home, the bottles are getting emptied, everything should be hunky-dory, and that's why being in the home matters. So ask them to show you how they do it.
Analyzing the question, because a lot of people are going to know that if I can't take my medications right, this is going to be a big deal for my being able to, be independent. Instead of saying, gee, are you taking your medications right? Maybe just sort of normalizing it. Gee, you take an awful lot of medications. Some people would have some problems with that. I know I would. Can you show me how you do it? Just so the tension is, switched off, and, normalizing things can just be, a trigger for a better explanation than, yeah, of course I take my medications just fine.
No, I really appreciate you bringing that up, Jan, and it really is true how you go about asking these questions that can be sometimes kind of intimidating. And, what if I'm taking a lot, or if I've missed a day, are they going to ship me to the nursing home? Are they going to not let me live here? And we're just trying to let them stay, but maybe figure out a different system if that one's not working.
But I also think sometimes they're proud of the system they have. I sometimes think you can frame it too as in if I'm in there as the nurse, I would say, I find it so interesting to see the different systems people have set up in order to keep track of these medications, because so many people take several. Can you show me, what's your system? How does it work? Because I might learn something new or whatever. Just different phrasing so that it's maybe something they're proud of, or like you said, normalizes it. And not puts them on the defensive, because it's hard, and sometimes people are a little embarrassed about the fact that they have 12 medications or something. And when we say medications, do note their herbal supplements and their vitamins as well. You might have said that.
I did not say that.
Okay.
Yeah.
I think the system piece is just so important, because, like, I just intervened with a woman who they didn't realize that her memory was so short term that she didn't remember whether she took her insulin or not.
Yeah. And
she had a 500 blood sugar.
Oh.
And, we just changed her system. Instead of 2 a day, just 1 a day. And a big calendar was made, and we put a little smiley face in the calendar that would tell her that she took it. And if she didn't, it wasn't there, because she could visually see, but she couldn't remember.
Right.
So the system is really, and she's trying, she's really trying, but I don't remember.
Right. That's wonderful. It's amazing. And those are the kind of interventions that make this so powerful, and that the physicians cannot make a calendar with a smiley face because they're just not there. But that's the difference between life and death for some of these people.
Yeah,
So
yeah.
absolutely. Yeah. Thank you.
Well, I don't know if this is, I encourage people to have a second set of eyes on their meds too, because it's easy for someone to be setting up their own meds and put 2 pills in one spot and then none in the next one and make mistakes. So even though I don't do the meds piece because I'm not a nurse, I do encourage them to have a second set of eyes, whether they do them or a child does them or their home health worker each week.
Yeah.
Thank you. And what happens with the participants' medications that they're no longer taking or that are expired? oftentimes they've got 5, 10, 15 bottles of old medications that they were prescribed and never took. They were prescribed and it got changed, or they've expired. And depending on the scenario, sometimes I will offer to take those if I'm like stopping by the police station on the way home or something like that. The police station and pharmacies do the take backs areas where you can drop those off. And sometimes once or twice a year, I'll do it in bulk. I'll say, I will take any of your expired or unused medications and drop them off for you. Instead of, a lot of times they flush them still or pour them down the drain or put in the trash, and these are not recommended to do anymore.
And I think what also happens a lot is they now know they're not supposed to put them in the trash or flush them down the toilet, so they hold on to them, not knowing what to do, and then they confuse them. And I think Sarah's experienced this a lot. So, as SASH coordinator, something you can do to help as well is maybe you can see, can you arrange a prescription drop-off at your sites, so that a pharmacy came to your site, maybe once a month or something like that, and had a prescription drop off, whatever that's called, where you put in your old prescriptions, because it's so dangerous when they have these old and expired things. And if it was organized, the nurses could say, it's happening next week, let's take these pills. I mean, you want to get them out of the way, or if you're a nurse and you're in there, you see it, put a big red X on it, or do something visual to mark it, because it's just so dangerous. And they're struggling because they've heard now they can't throw it in the trash, they can't flush it down the toilet. Well, they don't know what to do. So that's something that we can definitely help with.
And if the person's had any type of accident or trauma or surgery or any type of cancer, then they've had old narcotics around. And with the narcotic and drug use and abuse, and what's better than to prey on is a little old lady who's got a ton of narcotics. So that's another reason to get them out of there. So they won't mistakenly take them, but nobody else will seek them and take them either.
Yeah. Be very vigilant. Yep. Do you, while we're on medication, I think we sent you all the medication management checklist that I think Sarah mentioned, and this is something that was developed by a group of nurses. Whoops, I opened the wrong thing. Don't look at that. There we go. Okay. This was a tool that's an additional tool I think if you're feeling like you have just those couple questions that are standard on the survey, and if you're feeling like you want to know a little bit more about how well this person is actually managing their medications and looking for some other factors, you can kind of keep this in your back pocket or have them handy. If you want to just dig in a little bit further, do you want to talk about how you use this or when?
I used this a lot during the assessment when we first developed this, and now it's kind of second nature when I'm doing the assessment to go through. We can go through a couple of them, like the review medications. Are they able to state the purpose of each medication? That, happens when I say, what medications are you taking and why do you do this? I mean, you don't have to go through and check this when you're with the participant. Just keep a mental list. Maybe the person's not taking their medications. They've got dexterity problems, severe arthritis. They can't open it every day. They can no longer open their bottle, or they can't see. So they may not have a cognitive problem, but they may have vision or dexterity. Medications change frequently. They weren't able to hear, hearing difficulties. Who supports them with getting their medications, or their medications mailed to them? Do they have to pick them up? Does somebody pour them for them? These are types of questions that if you ask, you can just say, like Janet was saying, normalizing this, and says, wow, this is a lot of medication. Does anybody help you with these? Or do you need help with any of these? Or does it seem to be working well? Do you ever have days where you seem to forget your medication, or you can't open the bottle because your arthritis is so bad? So this is like a person-centered piece of the medication management checklist. And recommendations and planning is, if it seems like the system they're working, or maybe they don't really have a system, isn't working, then what can we do to help put a plan into place? Would it be better if maybe they really shouldn't be driving? Can we have the medications delivered or mailed to them? A VNA referral for safety concerns. The VNA, the Home Health Agency, that we work with as a partner, can do medication management if there's a skilled need. So this is a checklist that I found myself going through really frequently and often when I was getting used to it, and then it became kind of second nature, and I would just stick it in the assessment when I was talking about certain items.
And also, please, everyone, keep bubble packs or Med on Time in the back of your mind if you see that for someone. And just because a pharmacy in your local area may not currently do it doesn't mean that they might not start. If you approach them and say, you know what, I have 5 people in the SASH program nearby that are all struggling, would you consider taking part in Meds on Time or bubble packs? And if you're interested in that, we can connect you with some resources around that. And we've had pharmacies start it up because that means someone might switch to their pharmacy and then they get money off that, basically. And it really helps our participants because now their local pharmacy will deliver bubble packs, Meds on Time, and that can be a huge help. So just keep that in mind too. Just because your local pharmacy doesn't do it doesn't mean that they might not.
Right.
There's money in it for them.
There is a local pharmacy as well as bubble packs. There's a local pharmacy off North Avenue who would fill participants' Monday through Friday box and deliver it a month at a time in his own box. So different pharmacies may have different ideas to help these participants out. They didn't do bubble packs, but they were willing to do this. So if they want to stay local or if it's right next door or whatever, talk to the pharmacy, and sometimes they'll be, flexible or have ideas. They definitely don't want to lose.
Right. These are their big customers.
These are the big customers. Keep coming back for more.
So that's the end of survey 2, which I call the kitchen sink survey. It's actually called General Health and Wellness, but it's got a lot in it. Any questions around survey 2 before we switch to the what are those validated screens? And those are more self-explanatory, but we'll go into the standard screens. But there is a lot in survey 2, so just know that not all the surveys are like that. But any questions on that?
This is called Survey 1.
That was survey 2. Survey 1, and you'll see these once you really get into DocSite.
That's the coordinators.
That's the coordinators do survey 1, which is participant information. And it's that first one I went over, very general information, demographics, contact information. Survey 2 is general health and wellness. Kitchen sink. Yeah. Uh-oh, mine's turned sideways. Look at my screen, everyone. Hopefully you have this paper in front of me. Okay, so we're ready to move on to what survey 3 or is the ADL, IADL. And I just want to say that our SASH assessment was developed based on the state ILA independent living assessment with some modifications of validated screens. So it's very similar to that with what we feel are some enhancements as well. So anyway, so this is the activities of daily living survey, sideways.
And some of these, you may not have to ask them. If they got up and answered the door and just came in from grocery shopping and were putting the groceries away, they'd just gotten off of SSTA, they answer the phone. Like, you can do a lot of these questions by observation. Can you get around inside your home? I'm not going to go through all of these, and you definitely don't have to with the participant. But some of them, are you able to manage your money okay? Do you have somebody from your family help you or able to do all of this? And it just helps us get to know the person better. So, like making a healthy living plan, or how can we use our SASH team to help this person if they are having trouble with any of these things?
And for those of you who may or may not know Choices for Care, a lot of this is used around eligibility for Choices for Care, nursing home, but many other systems in the state are also using this checklist, but we find we have a much more comprehensive view of the participant. So even if they can't do a few of these things, we feel like they can still stay in their home. And so it's important to kind of keep track of this, but also keep track of what they can do in the big picture. So people will often ask us for what are their ADL or IDL scoring, but anyways.
Okay. Are we on falls?
Yes, survey 4 is falls.
Falls. This is a big thing with our population. It's pretty self-explanatory. The thing I want to mention is anytime that after you do this assessment and you do hear that the person falls, if you could do it then, go put in DocSite that day or the next day and, put this additional fall in there so it's documented. Oftentimes they can't remember in the past month. Go ahead, Yanni.
Or if you're adding.
Yep. So here's how this one works. So there's 5 questions in this survey. It's very short. And if you're looking at the instruction sheet, hopefully you can see on my screen, the first 2 boxes, there's a red note in here that says complete only at annual assessment. So that means once a year. And that question is, did you fall in the last 12 months? Yes or no? So the first assessment, you're going to ask them yes or no. Well, it's just based on what they tell you. If yes, how many times? And they'll go, oh, I think 2. Great. Well, we don't know if that's accurate or not. So just say that. And you're going to ask them that same question a year later. But in between that very first time and a year later, every time they fall, you're going to answer the next 3 questions. So you come into work Monday morning and someone comes up to you and says, Betty fell yesterday. The ambulance came, but she didn't go in. So you're going to then, probably check in with Betty and say hi. But you're going to say that on June 23rd, Betty fell. What was the cause? Tripped on her oxygen cords because you talked to her. Disposition, what happened? You could say other, and then there would be you're going to put in a note that says tripped, the ambulance came, she refused to go in, seems like some minor bruises. Sarah will check in with her later. So we're recording it. So then a year later, we can actually then, DocSite will do it for us. They're going to add up how many times we recorded a date of a fall. So we'll actually see that it was 8 falls last year. And we'll still ask them, how many times did you think you fell in the last year? And they'll go, I think maybe 2. And I'll go, okay. And it's okay because we're actually going to have an accurate count of it. But I think also at that first assessment, if they say I think I fell twice in the last year, you'd say, when was the most recent time? Can you tell me about it? And they may not know exactly what the date was. And, they might remember, I think it was around Christmas. Fine. You can just put in December 25th. On that first assessment, it doesn't have to be perfect. What's more important is what happened. If they did trip on an area rug, well, that's a good indicator of something we can work on, So just kind of figuring that kind of stuff out. Do you want to add to that?
I find that oftentimes people don't tell you when they fall as well. I went to visit somebody and he says, I've been falling. I said, what do you mean you've been falling? I've been seeing you every week. Well, they don't, it's something they don't want to tell. They're embarrassed or they're nervous or they think it's going to, kind of get their ticket out of independent living. He said, I've fallen like 3 times in the past 4 or 5 weeks and I had no idea. And I'd been seeing him every week and I had no idea this person had been falling. Either you walk in and somebody else tells you they fell or a lot of times they don't tell you. It's, a proud and pride thing as well.
So just get as much information as you can. Okay, go ahead, Annie. Yeah.
Put it in if the person didn't go to the hospital, if they just fell.
Oh, yes,
definitely.
Please.
And that was, okay, so and maybe VNA nurses also should know that information? Everybody knows the same information.
What do you mean the VNA?
Well, I wasn't sure if everyone's getting the same information as far as what to put in DocSite regarding falls.
The VNA SASH Wellness Nurse?
Yes.
Whoever knows. If the nurse is there and the nurse is told, put it in, and if the nurse isn't there because they do only minimal hours per week, you could put it in. Anybody can put that in DocSite.
They should know to put it in whether the person goes to the hospital or not.
Yes, please.
Okay.
So if Gladys is there and there's no SASH coordinator around, she'll put it in.
Okay.
Anybody can put it in, and they should be documented whether they went to the hospital or not. It's fortunate, oftentimes when people fall, they don't always have to go to the hospital.
And I had to go to the hospital.
I know.
Broke his arm.
Yeah. Well, and often, so that's why on these choices of disposition of fall, ED visit, hospital stay, other, NA, you could do other or NA. I think we added other because people wanted, went to brother's house, fell. That's what we want, or NA, and then just state nothing. But we want that because often what happens, they fall, either the ambulance doesn't come, they don't tell anyone, and then a week later, they have a broken arm. And then you figure out, they say, oh, well, I did fall last week, but I didn't think anything was wrong. And so you do want to record it every time it happens, even if they don't go anywhere, because we need to figure out what's causing the falls, what's going on. And it may just be a scatter rug, but it may be that there's something up with the medications or.
Yeah, and I think also as they, helping them to understand as you get older, your balance is not, it's a process of getting older is that, your brain doesn't, your balance is not as good as it was when you were, 20, 30, 40, and that's part of aging. And I think that helps to normalize it, and they're more willing to share, well, I did fall. I said, well, this can happen, and we can help you with balance, including, occupational therapy and, what's going on in the house. But sometimes it's just about balance.
Perfect. Yes. Yep. Great.
Thank you.
Any other questions?
Speaking of falls, the next is the fall risk assessment tool, and this is something that you do not have to do in front of the participant. You're going to have all of these, answers by the end of the assessment.
But just don't forget. So this one you don't have to ask them. So a lot of people save it till later to enter, but don't forget, because this has to be done at minimum once a year. And the state and the home health agency, everyone's required to look at this. Besides people collecting data on it, it also tells us a lot, because this measures, this is a validated screen to measure what's this person's risk for falling based on other factors in their life, besides just normal aging and loss of balance. So, and you all can also then run reports on your population to say, who are my folks out of my 50 people? Who are the ones that are at the highest risk of falling? There's 3 levels here. Take your highest risk group and say, hey, and go talk to them. Say, we're going to start a matter of balance class, and I think you might really enjoy it. And not all of them are going to want to join, but you can do outreach specifically to those people and really see and make an impact in their lives. So it is really important to make sure that this information gets in. It'll automatically calculate for you. And then you also have the option to do a tug test, which is watching a person walk. There's instructions on the forum for how to do that, and either SASH coordinators or nurses can do a tug test at any time. It's just timing and watching a person walk. So we have an instruction sheet for that. It's a nice indicator of gait and speed and kind of balance. Okay.
Mobility is pretty self-explanatory. Does a participant drive? It does not ask us if they should drive. It just asks us if they do drive. New walkers or wheelchairs, ramps or anything like that. Oftentimes, people in the SASH team, when you have a team meeting, you can discuss the best resources to help them get new walker or wheelchair or ramps. The next one is the nutritional health checklist. This will score automatically, and this is pretty self-explanatory.
And this gives you a lot of good information on your participants. So but it's very clear and standard. And then this is something also that you can do for outreach around programming once you get these scores. Who are my folks that are most at risk for nutritional risk? And again, you could maybe do an educational program. They may or may not come. And then you can also do some individual targeted interventions.
Okay, on to cognitive.
Cognitive.
These are the 3 things that we do, and most of you I had do in the training in April. I put you all on the spot, having you remember the 3 words, or name the animals, and or draw the clock. And then we had a Cathedral Square staff meeting several weeks ago where we were introducing the SASH program, letting the rest of the staff know what the SASH program did. So we came around, they went around to a service fair again, and we asked them again. And the cognitive screen isn't a diagnosis. Again, it's a tool that we can use. And this is somewhere where we're also normalizing things like Janet was mentioning, and not trying to put them on the spot and think that they have dementia or Alzheimer's and they need to go to a nursing home. But this is just, are there times where you feel like your memory isn't great, and that if they want to know if they failed, they're really concerned that they may have failed this part. And I kind of make this I say this is a fun part, we're going to do it's a game. And it just tells me, how is your mind working? Are you really stressed out? And so that's why you're having trouble thinking, or are your medications, not meshing well together? Are you sleep deprived or having a lot of pain? All those different things can affect our memory on a daily basis, whether we're, 30, 40, 70, or 80 years old. All of these things can. And when this will score automatically, and this is something we do every year and is a tool. And it's a month or 2 ago, we had our cognitive specialist nurse, Maria Wicker. She did a presentation on our call, about using the cognitive health screening and how to do it. It's the nurse's part, but the SASH coordinator oftentimes can come in and watch, or I've done it to them as well, so they know what our participants are going through.
So and the results of that call, I want to show you all. I'm in DocSite now. Hopefully you guys can all see my screen. Some really good tips came out of that. So we wanted both a clear instruction sheet, and a lot of the nurses were saying, I'd love some phrasing tips because people get nervous around the cognitive screen. How do I make them comfortable? They always want to know if they passed or failed. So there's a couple places in DocSite where you see this little I button, and you can click on it if you scroll over it. So what we did is we put in here, if you click on that, there's 2 links you can click on. And one says screening instruments. So you click on that and it basically opens up a PDF. So you can go to it live while you're with someone, or you can print these out. So this has both the instructions and how to score it right there. The other thing on that info link is it says SASH Cognitive Screening Wording Tips. And this is something that you all might want to print and have and get familiar with. So this is some suggestions that came from Maria, who's a dementia expert, and of how to kind of phrase things, build rapport with the person, how to introduce it, some questions to ask before, and then some phrasing tips for after as well when you're doing it. So you can access these all straight from DocSite. You can print them out, and it says people want to know how they did. You can just say, thank you for helping me understand how your concentration is working, and this was very helpful. And if you beforehand asked them, and they did say, yeah, I've been struggling with my memory, you can just say, yes, I see what you mean, that your concentration is bothering you, or that your memory is giving you trouble. And then you really want to talk about working with the primary care. The next step is, let's talk to your doctor. It could be, like Sarah said, it could be from medications, stress, who knows? You are not diagnosing. You're just kind of trying to see where things stand. And Sarah's done this to me in front of a live audience, and I did miserably on it, and I seem to have recovered slightly. But yeah, so there could be lots of things going on. You definitely don't want them to think that you're going to give this to them and then be like, oh, you have Alzheimer's.
You failed.
Yeah, you failed.
You have Alzheimer's, you're going to nursing home.
Right. So there's these tips in here. So print these out or review them, or you have them. Questions on the cognitive screen? And also all of our nurse calls and any of the memory care calls are recorded, and they're accessible on the forum. So if anyone wants to go back and listen to those, you're more than welcome to.
We want to know what type of interaction you had with the person. Did you go to their home and visit them? Was it a group presentation? And what came out of that? Did you refer them to the primary care doctor? Were you there for support? You did something with family, education. It's pretty self-explanatory, and you'll do more of that in DocSite training.
Yeah, just remember to track what you did. Yeah. Okay, and then you go into, at the end of an assessment or anytime you interact with someone, you go into what are called encounter notes. And we're going to spend a little bit of time talking about encounter notes.
Encounter notes are exactly what it says when you have an encounter with a participant that you think is relevant and needs to go in their chart or record. Having a great day, status quo, everything's fine, doesn't need to go in there. Was complaining of burning with urination, help set up follow-up with primary care doctor, then the next week, started on antibiotics, feeling better, and then you may not have anything for 6 months. If the person, there's not really much to document on. Other residents or participants, it's like an every week thing that things are going on. And after the assessment is complete, it's good to have like an initial little paragraph on SASH assessment complete. Go through and almost identify anything that we would be helping them work with, medications. Do the Monday through do the weekly boxes. Feels like they don't ever miss anything. Would like a referral to physical therapy for, feel like loss of balance or something. Just things that, like a little paragraph summarizing the assessment and what we can help this participant do. If you've never met the participant, this is the initial thing of kind of what they're about. And the other thing that can kind of go with that I want to mention here too is it's participant at a glance. Some people use these and some don't. If you're ever having somebody start new or cover for you. Oftentimes it'll be for nurses. There aren't many nurses. We don't have many hours. But if somebody's covering their site or panel for a week or two, and there's certain participants you'd like to see, you can use the participant at a glance. It kind of just gives a bird's eye view of what this person is about and the keys and highlights about them. It's kind of like a report sheet if you ever were working in the hospital or a doctor's office or anything and wanting to know the key points of somebody. It's like almost like a face sheet. So the encounter notes.
So I think, as Sarah said, after your initial assessment, you'll have a longer case note than you would, or encounter note than you would at others. Just to summarize, as you go through the full assessment the first time, you're going to be taking notes on the side, things that come up in conversation, and that you'll want to document what is useful to other team members, what's action items to follow up on, things like that. And from then on, the working notes will have a certain flow to them.
This should be on a sheet of paper, just key items that are good. What does good documentation look like? And good record keeping enhances patient care, giving a clear and purposeful record of both care given and care planned so that all healthcare professionals can achieve the best outcome for our participants. And these points or items came from a really great article that Stefani found. It was called Practice in Nursing and a Guide to Case Notes and Record Keeping.
And the reason we're touching on this is over the years we've had a lot of discussion about what kind of notes to put in there. And you have SASH coordinators, you have nurses, you have people who have different educational backgrounds, you have social workers, RNs, all different backgrounds. And then even within the RNs, some people are been trained in SOAP notes, other people different training. And so we just want to get, Sarah and I want to give you just some basic tips and guidelines. There's no rules around this documentation, but just some general good practice guidelines to go over that supports the whole team. So we just made a few notes on this. Well, first of all, this is a quiz. Where are the case notes recorded in DocSite?
Is it
Is it
comment?
online VP entry?
Yes, I heard two people say visit comments. Yes, so you can put it in the online VP entry. Yes.
Grab a chocolate.
Okay. It's called Visit Comment Review, and then Encounter Notes in the online visit planner is what we were showing you. So I kind of want you to know that really because DocSite uses different names for things. So it all goes to the same place. Anything in DocSite, if the same thing is asked two different places, it's always going to feed to the same place. So don't let that throw you off. And then why record case notes? We really want to record the reason a decision was made, the actual intervention that was taken or not taken. So you want to say why did the person not go to the hospital, or why did you decide, not to dress the wound, or whatever it was. So people just need to know, and a change in the status. So again, if you saw them and everything looked great and they're happy, you don't need to make a case note. But if there is a change from the way they were, record that, because that's a clue to something happening, a point that people need to know.
In an encounter note, I don't know about any of the nurses or anybody in the medical profession, but it was our most famous statement: if it wasn't documented, it wasn't done. So this is, if it wasn't recorded, it hasn't happened. So if it's something kind of crucial or you'd want to know about, if you were meeting this person for the first time, reviewing their chart, something that is important that you'd want to know about. And it's a record which contains information and personal data about this person. Good record keeping is an integral part of nursing practice. Legal claims arise when great documentation isn't done. So if you can go back and have a paper trail, then it's a lot easier to sort through. Use of abbreviations. We used to use a ton of abbreviations in healthcare, medical world. For example, DOA. Anybody know what DOA is?
Dead on arrival.
Dead on arrival. Anybody else know what another DOA is?
Date of arrival?
Date of arrival or day of admission.
Date of admission.
So if somebody was DOA, if you said a family member, if you were talking to a family member, said, yeah, they were DOA, were they dead on arrival or did they come in the day of admission? So try not to use the old barbaric abbreviations that, yes, write it out. Be factual, consistent, and accurate. You know, this is the thing I was pointing out. If you were caring for this participant or meeting them for the first time, what would you want to know about this person? And what happens when things go wrong? The good record keeping can come in handy for you and the participant. Social media can compromise the patient confidentiality. Now with texting and iPads and email, so it's just something to keep in mind about the social media that we are keeping when you are emailing one another and aren't in the Cathedral Square email, or doing to another corporation if you need it encrypted or not, if you're using identifiable triggers or.
And anything on the forum is technically public, so it's a great resource sharing place, and people have been using it a lot, but just you don't want to put participant information up there, which I think you all know, but things like that. And we do share success stories on there, but without names. I think most of you know that, but we did have a time once where a nurse said, well, I've been texting with my SASH coordinator about a participant. Is that okay? And we said, are you using the name? She's like, yeah. We're like, no, that's not okay, because you feel like your cell phone's right, but if you're texting, it's not, you can call people.
And if it's by identifiable.
Right. Yeah. Right. Yeah, that's good. Oh, okay. Do you want to play your game before we do this?
Let's do our game really quick because, this is a little Jeopardy of, about abbreviations, and it's called Say What. So I've got $1, $2, $3, and $400.
Okay, does someone want to pick a dollar amount for a question?
Category. Yeah, pick a dollar amount.
$300.
300.
300 for
Okay.
A, please.
APS. What are the two different?
We're looking for two answers. What is
Adult
APS?
Protective Services.
Adult Protective Services, and what else could it mean?
That's great. That's one. You get chocolate.
You get a chocolate. Look at her, go right and get it.
What else? Anyone from any site?
This is a really tough one, and I ran into it not too long ago, and it was in a hospital note. It was, it said APS consulted. I was like, what is going on? It was Adult Pain Service.
All right, you get a chocolate, Sarah.
Thank you. Okay, that's 300. 200. STD.
Transmitted disease.
Sexually transmitted disease. And what else?
We got Williston's all over the sexually transmitted disease. Okay, other sites. What's another STD?
Standard of daily living.
What is that?
Standard of daily livings.
Standard daily living. Okay, grab a chocolate. The other one that could be used is short-term disability. Okay, we got 100 and 400 left. 100. Maria. PMS.
That one.
Post-menstrual syndrome. Go ahead.
Okay, we got the pre and post-menstrual syndrome. What's the other one? This is more for SASH coordinators. I threw this in just for you. Property management systems. Okay, last one. Who wants 400?
I'll go for it.
Okay, someone out there.
Okay, 400. It got the daily double. SASH. This is one that you can frequently use, but I tell you, when you Google SASH, what pops up? Anybody know any other abbreviation or acronym? What's that?
It is sexual something. But does anyone, that's the second S. Does anyone know what SASH stands for in the first Google hit?
So we've got support and services at home.
Not the first Google hit.
Sexual adults or something.
I get some chocolate. It's the Society for the Advancement of Sexual Health.
Oh my gosh.
Yes, I had a nun tell me that 3 years ago.
So when you're working for SASH,
yeah. And we do know it's a very reputable organization. They help a lot of people. And they have a lot of people who go there. So we probably will never get more hits than them. I shouldn't say never. When we're national, we are going to take over and be the first Google hit. But right now, just sashvt.org. Just make sure you tell people to add the VT on there. Otherwise, they'll get something very different. Good job, everyone. I think everyone should eat their chocolate.
and everybody can enjoy the chocolate.
Yeah.
Champlain chocolate.
Leisha, thank you, Sarah. That was an awesome game for the chocolates. So we just have a couple minutes left, and I just want to go over the last thing. There was this incredible presentation put together by a professor at UVM, a nursing professor, and a physician in Chittenden County. And they created this training, which I'm not going to do the whole training for you, for physicians who are struggling with adjusting to having to work with EMRs because they want to work with paper charts and they just want to sit and talk with people. And they're really struggling with having a computer in the room and having to type and work with people. So they created this presentation, and they've been doing it around the country at a couple places, and it's copyrighted, but Mary Val Palumbo said we could use it here as well. So I just want to, you have a handout that goes over it a little bit, and the acronym is RESPECTS. They play Aretha Franklin when they do the training. But the concept is, if you have an internet connection at your sites, and when you feel comfortable, use the iPads, or if you have a laptop with Wi-Fi, whatever you have, you can make the technology a part of this conversation. It will save you time in the long run, especially nurses that just, you don't have a lot of time. And again, not everything, but those screens at the end, you can just click right through those when you're with the person. But keep in mind, you don't want to make a barrier between you and the person. You wouldn't want to have them sitting on the other side of the table like I am now with a computer between you, because that is really intimidating. So the couple of tips on here, I mean, you can read, it has tips and then it has benefits. And it's really, read the visit planner, review the record before you go in so that you're not reading and talking, because that's off-putting. Enter the room and welcome and warm the person. So you're going to be in their apartment, so spend some time with them before you dive into the screen. This is a great tip. Say everything that you're doing. So when you are entering information, just talk and enter at the same time. Say, okay, no, so you just told me that you take Aricept. So what I'm just entering, you take Aricept, 10 milligrams, and did you say 2 times a day? I'm just putting in 2 times. Just if you can get in the habit of doing that so that they don't think anything devious is going on. And one of the things, we're going to get to position of the computer, is that they said you can really actually make a triangle so that the computer or the iPad becomes a third person in that conversation. They can see what you're entering. Let them see it so that it's not mysterious, especially with this generation, and let them see how great it is that it's in there. So that's position the computer. So however it is, and the iPad can lay flat. You can just set it on their kitchen table and have the three of you, the iPad, you, and the person, looking at it together. Engagement position I found really interesting. They basically said that if you have a computer and you just turn the upper half of your body to look at someone, you're not really fully engaged, and there's research behind that. You've got to stop and turn your whole body towards a person, and that really triggers in the brain, I'm fully focused on you. So when you're just talking to them, turn your entire body. And then when you're typing or entering, you can turn back and then talk through what you're entering. Computer confidence, well, that's something y'all can work on. We either have it or you don't, but it's something you can keep working on. And if you're not that confident, I would share that with them. You could say, I'm learning a new system, so this may take me a while. Can you help me find the right box to check? That's what I would do. Teach your patients, so I would, again, include them. And then when you're signing out, summarize and say, now I'm logging out, your record is completely secure and gone, no one else can see it. So anyways, you can read through these. They're just some tips, and I encourage people to eventually get comfortable. It'll save you time in the long run and kind of help with the workflow. And so thank you, everyone, for being here today.